Earliest manifestation of acquired hypothyroidism will be deceleration of the growth. Down syndrome patients, 1/3 cases are presenting with hypothyroidism because of abnormal autoimmune function. And to your surprise, acquired untreated hypothyroidism can present with precocious puberty because high TSH can crosstalk with FSH receptor to produce more estrogen, so they can present with precocious puberty also. Welcome back to my channel in part 2 of acquired hypothyroidism. In today's video, we are going to discuss many MCQs as well as one-liner related to topic hypothyroidism. Do not skip anything, watch till the end. Hi, I am Dr. Triyavira Animalde, pediatrician and consultant neonatologist. I'll be your guide for pediatric subject. If you are new to my channel, please do subscribe and give like to this video because lot is going to happen for pediatrics on this channel. Question number 1. Hypothyroidism in infancy is characterized by, your options are constipation, coarse faces, C, wide open cranial bones, or it is D, hyperthermia. And the correct answer is, we all know the correct answer is option D, it is hyperthermia. Hyperthermia is associated with hyperthyroidism, not hypothyroidism. On the contrary, low thyroid hormone will cause cold intolerance in patient, will lead to hypothermia. So let's discuss the physiology of thyroid hormones. It has effect on many organs starting from cardiovascular to renal system. In heart, it is going to increase the heart rate, myocardial contractility, increase the blood pressure. It increases the systolic blood pressure while it decreases the diastolic blood pressure. It has many effect on the growth. Bone and teeth eruptions are dependent on thyroid hormone. On the CNS, it increases the synapse, axons, and it also helps in myelination. On GIT, it will improve the motility as well as appetite. On the skeletal muscular system, it will increase the contractility, it will increase the muscle growth. On the metabolism, the net effect will be reducing the cholesterol. It increases the basal metabolic rate. On the reproductive system, enhance the ovulation in female and it enhances the spermatogenesis in male. On the renal system, it increases the GFR. Thyroid hormone is very important regulator for epidermal homeostasis. So if there is absence of thyroid hormone, it can cause dry, itchy skin as well as the coarse and scaly skin. In absence of thyroid hormone, the eccrine grade secretion is reduced, so there will be absence of sweating and there will be a presence of dry skin. Thyroid hormone inhibit the synthesis of glycosaminoglycan. If there is absence or a low thyroid hormone, there will be a more synthesis of glycosaminoglycans which accumulate inside the skin, and this is the important reason for myxedema. It will cause dry puffy facial skin as well as it has some effect on the hair follicle also. Absence or thinning of outer third of the eyelashes, which is called mydrosis. Thyroid hormone is necessary for muscle development, contractility and muscle regeneration and muscle development. In absence of thyroid hormone, there could be easy fatigue, decreased deep tendon reflexes, hypotonia as well as muscle weakness. Thyroid hormone is very important for BMR as well as the thermoregulation. Its deficiency will lead to hypothermia, lethargy, fatigue, sleepiness and low energy level. Thyroid hormone play vital role in bone mineral homeostasis as well as the bone density. Its deficiency lead to delayed the skeletal maturation and there will be open cranial bones which is called craniotabes. Thyroid hormone is necessary for GIT motility. In absence of thyroid hormone, the presenting symptoms could be constipation. Thyroid hormone absence will reduce the erythroid, can cause bone marrow depression, and there could be a presence of B12 and iron folate deficiency, which is the most important cause of anemia in a patients who are suffering from hypothyroidism. Low metabolic rate, low cardiac output will lead to bradycardia as well as hypotension. Because we discussed thyroid hormone is very important, play vital role for maintenance of the heart rate as well as blood pressure. Absence of thyroid hormone can lead to menstrual irregularities, hyperprolactinemia as well as galactorrhea. Earliest manifestation of acquired hypothyroidism is deceleration of the growth. This is just a combination of the all effect of absence of thyroid hormone or hypothyroidism. You can take a screenshot if you want. So question number 2, which is not a feature of hypothyroidism? Short metacarpals in hand, precocious puberty, delayed bone age, altered upper segment to lower segment ratio. We have discussed almost all of the symptoms in a previous slide, so it will be easy for you to give answer The correct answer is short metacarpals in hand. Short metacarpals in a hand is a feature of Turner syndrome. I have made a very beautiful video on Turner syndrome. If you have not gone through it, please go through it. Link is in the description box, as well as there is I button. Precocious puberty, delayed bone age, and altered upper segment to lower segment ratio could be a part of hypothyroidism. How it's going to cause a precocious puberty? First of all, we should know what is precocious puberty. Precocious puberty is presence of secondary sexual characters before the age of 8 years in girls and before the age of 9 years in boys. It could be a central. Central means it is starting from a hypothalamus, gonadotropin dependent precocious puberty and gonadotropin independent precocious puberty. In case of hypothyroidism, there will be an increased TSH because of a negative feedback, and this cross react with the FSH receptors to produce more estrogen, and this estrogen will lead to the signs of secondary sexual character before the age of 8 years in girls, peripheral precocious puberty. Question number 3. Complication of hypothyroidism includes all except coagulopathy, SIADH, muscle weakness, or it is hypokalemia. The correct answer is option D, and that is hypokalemia. Hypokalemia is because of hyperthyroidism. What is happening in case of higher level of thyroid hormone? In case of hyperthyroidism, it will stimulate a sodium potassium ATPase action, and it will lead to hypokalemia. Hypokalemia is a part of hyperthyroidism, not hypothyroidism. Now, how it going to have these 3 complications? We all know that because of low thyroid hormone, there will be decreased cardiac output. Because of that, there will be increased antidiuretic hormone secretion, and there will be a water retention, will lead to hyponatremia as well as SIADH. While reduced thyroid hormone can impair the coagulation by action on the coagulation pathway, and it can lead to coagulopathy. Thyroid hormone, as we all discussed, that very important for muscle development, contraction and regeneration. In absence of thyroid hormone, there could be muscle weakness. The next question is common presentation of juvenile hypothyroidism is all except growth retardation, mental retardation within 2 years of age, moist skin, or umbilical hernia. We just now discussed symptoms and the causes of hypothyroidism. So correct answer is moist skin. We all know that it reduces the eccrine gland secretion. It can lead to dry skin but not the moist skin. As we all know, growth retardation is the earliest manifestation of hypothyroidism. We all know that it is the most common preventable cause of mental retardation. The question number 5 is an 8 years old child present with lethargy and multiple epiphyseal breaks, Wormian bones with growth retardation as well as mental retardation. What is the diagnosis? Wormian bones is a cranial bones which is present in the skull. It is palpable because of a delayed skeletal maturation, and it is seen in a which condition? Your options are rickets, hypothyroidism, scurvy, or hypoparathyroidism. It is hypothyroidism, but why it is hypothyroidism we are going to discuss. So correct answer is option B, hypothyroidism. This child is suffering from hypothyroidism, but why it is not scurvy or rickets or hypoparathyroidism? In case of ricket, it is not associated with mental retardation, so that is out. In case of scurvy, it is also not associated with mental retardation, and there are other features which is present which is pointing toward the scurvy. While in case of hypoparathyroidism, it is also not associated with MR, and as well as there will be a presence of twitching and spasm, which is a very particular presentation of hypoparathyroidism. The next question is a 1-year-old child present with short stature, lethargy and constipation. Clinical examination shows palpable goiter. Laboratory investigation revealed a low T4 as well as elevated TSH. Which of the following is most likely diagnosis? Now it is 1-year-old child. We all know it is short stature, lethargy and constipation, so it is all pointing toward hypothyroidism. There is a presence of low T4 as well as high TSH, so again it's a laboratory confirmation of hypothyroidism. Now we need to point toward the etiology. Here it is a one important clinical clue, that is palpable goiter. So thyroid dyshomogenesis present with palpable goiter, while thyroid dysgenesis will not have a palpable goiter because there is not a formation of thyroid gland only, so this cause is out. Central hypothyroidism will also non-goiterous cause of hypothyroidism, as well as there is a presence of other pituitary related hormone deficiency. And option D, TSH receptor blocking antibody, is also non-goitrous cause of hypothyroidism. So correct answer is A, thyroid dyshomogenesis. Rest 3 are an important cause of non-goitrous hypothyroidism. Now, what are the other causes of goitrous hypothyroidism? One is thyroid dyshomogenesis, very important cause, has to be remembered by you, asked many times. Iodine deficiency as well as passage of maternal antithyroid drug to the fetus also can lead to goitrous hypothyroidism. So these three things has to be remembered. The next question is short child present with low T4 and raised TSH as well as swelling of pituitary. What is the diagnosis? Options are primary hypothyroidism, pituitary tumor, TSH secreting pituitary adenoma, or it is TSH resistance. The correct answer is it is primary hypothyroidism. But why it is primary hypothyroidism in spite of presence of swelling of pituitary? We are going to discuss in detail in upcoming slides in few minutes. If we consider a pituitary tumor, there will be a raised intracranial tension as well as there will be a reduced growth hormone and the signs related to reduced growth hormone or a growth hormone deficiency. While if we consider TSH secreting pituitary adenoma, all the way it will cause high T4 and it will have all signs of hyperthyroidism, not a cause of hypothyroidism. And TSH resistance will also have a high T4 as well as normal or increased TSH. So these three causes are out due to these three reasons which you need to know. These last two C and D will present with high T4. So low T4 is given, so that is also out. So what are the causes of acquired hypothyroidism? Could be autoimmune like Hashimoto's thyroiditis, celiac disease, diabetes mellitus 1, autoimmune polyglandular syndrome, APS1, Down and Turner. Like we have seen that these are having autoimmune abnormal function which can lead to hypothyroidism. It could be a drug induced like amiodarone, phenytoin, methimazole or PPU. Or it could be because of radiation, cystinosis, hypothalamic pituitary disease or thyroid. This is less than 1% of the cases and this may present with the signs of central hypothyroidism. 95% of the cases it is because of autoimmune disease. We should also know few words about APS1 and APS2 syndrome. APS1, the short form is FMEG syndrome, that is autoimmune polyendocrinopathy. C stands for candidiasis and ED stands for ectodermal dysplasia. This is all related to APS1 syndrome. This can also present with the hypothyroidism. While APS2 is also known as a Schmidt syndrome, in which there will be a thyroiditis, Addison disease as well as type 1 DM. Question number 8. Examine the picture carefully. The child is at risk of developing which of the following endocrinopathy? Hypothyroidism, growth hormone deficiency, diabetes mellitus or precocious puberty. We all know the facial feature and dysmorphism is suggestive of trisomy 21, there is a mongoloid slant, there is a depressed nasal bridge, macroglossia, and all features are low set ears are suggestive of Down syndrome. So correct answer is option A, hypothyroidism. In the beginning of video only we discussed that 1/3 of the patient of Down syndrome are associated with hypothyroidism and this is because of abnormal autoimmune function. The next question is clinical feature of neonatal hyperthyroidism in a newborn are all except triangular faces with craniostenosis, CCF, advanced osseous maturation or goiter is rare. The correct answer is option D, goiter is rare. Goiter is always present in a congenital hypothyroid infant. These three are almost opposite of hypothyroidism and these three are also present in a case of neonatal hyperthyroidism. So neonatal hyperthyroidism, there will be increased thyroid hormone. This is due to transplacental passage of thyroid stimulating immunoglobulin due to maternal grave disease. Clinical feature could be vomiting, diarrhea, poor weight gain, ophthalmopathy and could be a CCF as well as craniostenosis as well as advanced osseous growth. TSH antibodies, low TSH and high T3, T4 will be the finding in a laboratory investigation. Question number 10. In hyperthyroidism, increased cardiac output due to all of the following except increased afterload, increased ventricular contractility, decreased total peripheral resistance and peripheral vasodilatation. The correct answer is we have to remember that how it's going to increase the cardiac output. To improve the cardiac output, the thyroid hormone improve the ventricular contractility. It will reduce the peripheral resistance and it will cause a peripheral vasodilatation. These three is very important to have a increase cardiac output, while increase afterload will not be related to increased cardiac output. So option A is incorrect. Rest 3 are correct, that it reduces the total peripheral resistance. So heart will increase the heart rate as a compensation, and thyroid hormone we all know that it enhances the ventricular contractility. That's all about today's lecture. I hope you all understood and learned well. Your suggestions are always welcome for the improvement of my video, and please let me know what else you would like to learn from me. Take care of yourself, study hard, study smart. Bye.